Sir, we are going in live in 5 seconds, sir.
Good evening, friends. We are in the module 12. Good evening, friends. We are in the module 12. And to take us through this journey, we have Professor Dr. Anguraj Sadanadam, who is a director at Center for Global Oncology and Research. We're going to learn about retrospective data, shelf life, and generalizability. He is one of the most accomplished persons to take us through this chapter because he himself is the pioneer who devised the risk classification in many cancers, including colorectal cancers. And to moderate the session, we have Professor Dr. AVS Prakash from IIM Lucknow. He is into data sciences, data privacy, data security, which are very essential components, especially for the retrospective data. And can we generalize those things? Over to you, Dr. Anguraj. Thank you.
Great. Thanks, Dr. Atlee. This is a great opportunity, and thanks for meeting all of you. This is a very interesting topic, and before that, good morning or good evening, wherever you are. So I'm Anguraj Sadanadam from the Institute of Cancer Research. I'm going to present about something that is quite important for everyday responsibility for doctors, whether you use AI or not, and how. And it's very important to understand the use based on many other factors that which we are going to discuss in next few minutes. The very important question that I want to ask here is, how old is the data that your AI tool learned from? And it's important that you know, and how many of you actually look into that is the major question that I want to begin with for this particular talk. It is quite important that we look into the update of each of the AI, because without that, there could be potentially incorrect diagnosis that could happen for these patients. And with that note, today's discussion is on the module number 12, retrospective data, shelf life, and generalizability. To be transparent, here are the disclosures from my side. So let's begin. There are going to be 3 sections that I'm going to take you through. The section 1 is going to give you introduction about some of the retrospective data from our own lab, and also introduce in general and tell you what are the pros and cons of the retrospective data. So on the right-hand side, you see a list of tools that we developed for diagnosis based on artificial intelligence. One is CRC Assigner for colorectal cancer, PD Assigner for pancreatic cancer, PANET Assigner for pancreatic neuroendocrine, which is a rare cancer type, GC Risk Assigner for gastric cancer, and also we did some work around breast cancer. So at this point, my interest is to take some of the examples from our own lab rather than criticizing others' tools, to give you the pros and cons of how much important to use the retrospective data, and also how one could generalize from those data in one way or the other. So here is the timeline. So we began our journey for developing such diagnostic AI-driven diagnostic tool beginning in 2010, where we developed the pancreatic cancer. We used the gene expression profiles. I will get that into a bit more detail in later slides. But question here is that what has changed over the time since we developed the pancreatic adenocarcinoma-based assigner, PD assigner. At that time when we were developing, gemcitabine was the standard of care, but today we have FOLFIRINOX, nab-paclitaxel, PARP inhibitor, and also the NRG1 fusion-based inhibitors. The AI tool that developed at the time didn't know or even acknowledge any of these treatments that were available. Then the question here is, of course, it's our own tool. The question here is that, is it applicable? We have been updating. I will let you know over the next slides that how we have been doing this. The next one is the CRC Assigner, which we published in 2011. At the time of publishing CRCR Center, immunotherapy was not an approved drug for colorectal cancer. Then the question comes that, is it still valid or not for today's sake? And also, we know that KRAS inhibitors are trying to get into the CRC treatment landscape as well, so that these all need to be taken into consideration. Again, we have been updating this tool, which I will mention later. Panet Assigner is the third one we developed, which was published in 2015. And at the time, the theranostics, lutetium dotonate was not approved for this cancer type. Again, the question is how much we could use it. Then comes the G-series Assigner, which is going to be quite interesting one, where we developed this using one of the earliest landmark trial, MAGIC, from Royal Marsden Hospital, which was using one of the chemotherapy, which is not a standard of care anymore. Finally, the tools and techniques that use also interfere with this aspect of the retrospective data. For example, I have listed a few tools which are AI tools which we have developed, but it's not always about the tool, but also it is about the tool sometimes that these retrospective data use can also be taken into consideration. With that note, in the next few slides, I'm going to take a few of these as an example and show you with respect to this current topic. So here is a striking statistic. I want you to remember that on average, it takes about 5 to 10 years for biomarker discovery from a lab to, the AI tool to take it to the clinic. That is the current status right now. It probably would improve over the time, but this is what the timeline that we have seen in our work. So it's also that when you take this tool from one lab to the other, one country to the other, one geographic location to the other, there are possibilities that the efficacy of these tools could reduce. I'm not saying it will always reduce, because it depends on what population was trained in the beginning matters. And also it is important that, how much it is updated, because, if it is not updated to today's scenario, then again, the efficacy of these tools would also drop over the time. So, again, this is only an approximation, but this would vary from tool to tool and the disease to disease. So the learning objective for here is that I'm going to tell you what the retrospective training data mean. I want you to be able to look at any of the AI tool by end of this talk to ask question: when was this trained? Does the era still match how we treat cancer today? I want you to understand why a model trained on patients from, for example, America or European cancer cohorts may not work reliably for patients in India. And finally, I want you to demand external validation of each of these tools, because the discovery data alone is not going to be able to answer every question. So finally, by the end of the talk, I want you to ask, who was studied in that cohort? Where was the AI developed and tested? And when was it trained? These are not technical questions. These are clinical questions. I think it is important for the clinicians to remember to ask before using any of these diagnostic tools, is my suggestion. So let me ask you a direct question here, and it's a fundamental question. Would you treat a colorectal cancer patient today using predictions from an AI model that was trained before immunotherapy or any landmark standard of care therapy currently available? Before we knew, for example, the KRAS, NRAS, and BRAF, which is currently called as extended RAS testing. Earlier, it used to be only KRAS-based testing. These testing is important currently for the treatment of the anti-EGFR, which is the cetuximab. So, before knowing this extended RAS testing, it was okay to rely on the KRAS alone, but given the extended RAS testing is important, we need to be updated right? That's the answer probably most of you would provide, and that is where how it should work. So the overall the biology of the disease stays same, which I'm going to repeat again and again over the time, but the treatment landscape varies over the time, and this needs to be taken into consideration. And that is the fundamental question that one would ask: that is that tool trained when all the current treatments were available? If not, when should we update, and how should we update is a question that one should ask before moving on to use these diagnostic tools. So what is retrospective data? Retrospective data are data collected from retrospective samples that were collected by the biobanks over the time, for which the treatment and related clinical information may or may not be available. So these tumor biopsies would be taken through different processes to collect, for example, RNA-based data or DNA-based data or protein-based data that will and also the electronic medical record-based information that will be used for understanding certain processes. For example, you probably are aware of this Cancer Genome Atlas, which is from America, and also International Cancer Genome Consortium, that they have collected cohorts of retrospective samples, which are still available. There are several thousands of data, but the question here is that would that data is up to date to provide information for current treatment is the major question. Similarly, how much of the electronic medical record based registry has been updated in there is a major question. And also, it's not about the retrospective. The clinical trial archives are also quite important. I'm going to discuss few of the trials, though we use retrospectively. However, we need to carefully consider before using them. For example, we used MAGIC trial and CA20, which I will discuss later. Finally, the biobank samples need to be collected in careful manner, and this needs to be also taken into consideration because if the samples collected were out of date related to the treatment, then it probably would not answer the question for the current scenario. So, like medicine, data also has expiry. So I'm not trying to tell here that retrospective data are useless. Retrospective data are really useful in a lot more ways. It helps us to understand, as I mentioned, cancer biology. For example, a stem cell-based characteristic of a tumor today is going to be the same stem-like characteristic tomorrow, 10 years from now, or 100 years from now. It is not going to change. It is the treatment aspect that is going to, and the guidelines from, for example, ESMO or ASCO, that is going to change, and connection between the biology and the treatment changes over the time. And that is what is the expiry that I'm just talking about. So it's quite important to understand that retrospective samples are quite important, but how do we use, in what context is very, very important. For example, again, KRAS G12C inhibitors or D inhibitors or any of the KRAS inhibitors are coming into the clinic, or PANDAS inhibitors. It is quite important to find data that has where patients were treated with that drug to train AI so that you can get much more accurate and clean results compared to retrospective data without those is the whole aspect of expiry that I'm meaning here. Sorry. All right. So with that, I just want to begin with gastric cancer. Though we did that in later part of our work. However, in 2016, this is the ESMO guidelines where inoperable gastric cancer patients were recommended to be treated with perioperative chemotherapy, that is chemotherapy before surgery and after surgery, or directly surgery. The question that we were brought to, we were introduced by the clinicians with that, how do we determine whether to give perioperative chemotherapy or surgery for these patients upfront? So again, this is 2016 guideline, and you can probably be wondering that, what about the up-to-date the treatment strategies for this is definitely not included. So the whole point here is to mention that this work which we did initially was not based on up-to-date guidelines. Hence, it needs to be really carefully considered before we move on to use this into the clinic. However, I just wanted to describe what kind of work we did, how these retrospective samples are going to be still useful, and what we should be doing to update them. So this work was based on the landmark MAGIC clinical trial, which was done by Professor David Cunningham and published in 2006 in NEJM. And the work really provided an opportunity for these inoperable gastric cancer patients to receive the first chemotherapy, which is ECF or ECX, and which contains the triplet chemotherapy and very aggressive therapy at the time. So we used this MAGIC trial as an opportunity to find who should be treated with perioperative or therapy versus who should be treated with surgery. So for this purpose, we moved on to use a technology called nanostring and the tumor biopsies, as I mentioned earlier. Because I wanted to just mention that these are very precious material. When we, collected these samples, we could able to get the RNA from these samples. And I just wanted to also emphasize that these are post-surgery samples. They were not biopsies upfront, so that is also important to know because it's not going to provide an opportunity before treatment for these patients, whether they should be treated with perioperative chemotherapy or surgery. However, we just wanted to check this out to find whether we can find biomarkers that can predict the treatment response. So we profiled RNA using RNA biology using nanostring technology for 200 genes, and we carefully curated genes which represent the gastric cancer. So from this, the take-home message is that these tumor biopsies, the data are highly useful. They do completely represent the biology behind this the gastric cancer, and a lot more were learned out of it. But at the same time, we could also use this to predict the response to the at that time available ECX or ECX therapy, which is a chemotherapy. We identified 7 biomarkers, which probably could read them. I think I'm not going to read this out loud, but these are all related to the gastric cancer that has been proven one way or the other. And we developed nanostring-based test to prove that these patients could be, sorry, I think something is lost in between, I guess. But sorry, I think one slide is missing here. However, we could clearly show that patients could be separated into low and high risk based on these simply 7 signatures, so that patients with the high risk should not be treated with perioperative chemotherapy is the whole point that we came up with. However, this was published in 2018, and since 2018, the chemotherapy for the gastric cancer patients changed to FLOT4, which is even more aggressive chemotherapy. And the question here is that is it still applicable or not? And again, it was based on the post-treatment surgical samples and whether it's accurate or not, are the questions that we are asking. And we are trying to upgrade this tool by bringing in the right therapy-based treatment as also the pre-treatment biopsy samples. Without this, at this point, though we have developed, I want to be upfront here that it is not completely ready to be useful in the clinic. So these are the questions that one would ask, and how far these kind of retrospective samples are useful. And it is not anymore directly useful for the patients. However, we will update them hopefully soon to get that to be useful in the clinic. But still, it is one of the first studies related to that. So that way it is quite interesting. Then moving on to the next cancer type, which is the pancreatic adenocarcinoma, we developed the PDA signature, which is called PDA assigner. This was the very first subtyping for pancreatic cancer. I still remember before this, 2011, pancreatic cancer was considered a highly homogeneous disease. It is not anymore. It is as heterogeneous as other cancers like breast cancer. So at that time, we used 67 samples. Of course, in 2026, of course, that looks like a very small sample size, but that is what in pancreatic cancer one would get because not many patients undergo surgery. However, we just wanted to see how we could really understand heterogeneity in this disease. We classified them into three subtypes based on gene expression profiles, as you can see on the left-hand side heat map, with the high expressing genes in red and low expressing genes in blue, and the colors on the top represents the subtypes classical, exocrine-like, and the quasi-mesenchymal. In the middle, you can see that these patients have different prognosis, with the quasi-mesenchymal having the poorest prognosis compared to the others. And the very right side, you can see that by using cell lines as a surrogate for patient samples, we modeled the response to chemotherapy at the time. Gemcitabine was the standard of care, and we found potentially the quasi-mesenchymal subtype would respond to it. However, it's highly variable with more and more data coming, but there is still this particular signature, would it be working for today's scenario, is a big question, because since then, FOLFIRINOX, which is highly aggressive chemotherapy, PARP inhibitors, and even immunotherapy and NRG1 therapy in small population of pancreatic cancer patients are being used. This doesn't mean this particular retrospective data and the signatures and biomarkers are not useful, but what we are currently trying to do, not only us, others who highly validated this work, are trying to see how we could update this with respect to the current treatments that's coming in, to make sure that we can predict the right treatment for the right for these patients. Of course, I hope in the future we could find much more related to this. And this slide pretty much summarizes what I just said now. And also one other thing I wanted to emphasize here is that the stromal biology, because pancreatic cancer is highly desmoplastic, was not much known in 2011, whereas currently we know much more. There are also subtypes based on the cancerous fibroblasts which contribute to stroma, and we know much more about the immune infiltration in pancreatic cancer, which was considered completely a desert. That's not true. So on other signaling events like NRG1 signaling and other things are getting to know in this pancreatic cancer. So all these need to be updated, and that is where we are working towards. With this, I'd like to give another example of CRCSN, and this is much more interesting because we have been updating this tool continuously over the time, if not fully, but most of it. And again, similar to the pancreatic adenocarcinoma in 2013, falling on pancreatic cancer, where it was difficult to model therapies because very few therapies were available for pancreatic cancer. Colorectal cancer also doesn't have a lot more, but at least better than pancreatic. So we used about 1,200 patient samples at the time with the gene expression data, and classified colorectal cancer into 5 subtypes, which are enterocyte, transit amplifying on TA, stem-like, inflammatory, and goblet-like. And as you can see, the biology was dominated here, and we on cellular type, this was done before the single cell era, knowing that the subtypes are potentially probably determined by the cell types, was the whole idea behind this particular discovery. And this is true today with the single cell data, which I will be slightly touching upon. So, what we found much more interesting here, other than prognosis, where the stem-like subtype, very similar to quasi-mesenchymal pancreatic cancer, was poor prognostic, we also found that there are 2 subtypes which are goblet-like and transit amplifying, which are on the top of the Kaplan-Meier curve on the right-hand side. If you can see, these patients were doing really well when they were untreated. Of course, such kind of data is very difficult to get. That's why certain times the retrospective data are still useful because they were untreated. It's much more useful. With a treated sample sets, then this question is completely different. These patients without treatment, they were doing very well. That means in the early stage, probably we could go for wait and watch for these patients rather than treating them upfront is a hypothesis that comes out of this. But below in the right hand side bottom, you can see for the very first time we boldly displayed this subtype based hypothesis of treating them in the primary or the metastatic setting. For example, the stem-like subtype, if you see on the left corner of that table, that we suggested fall-free irinotecan-based therapy in the metastatic setting. We know that this particular chemotherapy is not used in the primary setting, but also we suggested that this could probably work if we select the patients based on this. And also I wanted to point at this light pink color, which is the transit amplifying subtype, which is a subset of it, which responds to cetuximab, and they are largely KRAS wild type. But there are also very few KRAS mutant samples which are part of it, suggesting that we can select patients who would respond to cetuximab. These two arms were largely validated by us using, again, clinical trial samples in a retrospective manner. The cetuximab was validated using a Canadian clinical trials CO20 trial, which proved to be true. And also I will show later slide as well, but also the irinotecan based therapy was proven as well. So it's quite important to go back, update and validate using the right clinical trial samples to do this. The most interesting one I wanted to mention is the brown one, which is the inflammatory subtype. At that time, the immunotherapy was not there. We didn't think of immunotherapy, as you can clearly see. So we said in the late settings, these patients probably, we don't know what therapy they should be treated with. The early settings, probably they should be treated with chemotherapy, but that's not the scenario today, because the majority of these patients are microsatellite unstable patients who are currently recommended to be treated with immunotherapy. So this is what I was mentioning, that you need to update it, and luckily we could update it, but still we haven't updated that part of it fully because we haven't got that right cohort to update it, but we are actually striving to update it. So these are all the points that I just wanted to mention, that the biology continues to stay irrespective of how many ever years you go, and that probably would indicate a response to certain therapies. But the question here is that, are those therapies really at this point standard of care or not matters? Without that, there is no point of using that particular biomarker or data to predict response to patients in real time. So, how did we update? And 2013, we published the first CRCSNR diagnostic tool using 1,200 patients and subtypes, which I already described. Then we joined with the Consensus Molecular Subtype Consortium, and with the other 5 other groups, our subtype was consolidated to Consensus Molecular Subtypes, which is highly cited and largely used. There are more than 6,000 citations for this paper, and that provided us an opportunity to take on and reach throughout globally. And from there, we developed a test called nano-CRC test. We reduced our number of biomarkers from almost 800 to 38 genes, used NanoString as a platform, and fixed paraffin-embedded tissues were used and to develop assays, and we tested this in 3,000 retrospective samples. Of course, some of those samples were clinical trial based, like treated with anti-EGFR cetuximab or irinotecan or other therapies, to update ours to show that whatever we found or hypothesized beginning in Nature Medicine very early in 2013 were true. And 2018 onwards, the trials were the trial samples are used. We have already published most of these things, which are publicly available, and I'm happy to provide those papers if you need it. So here is an example of, again, how we updated. Tribe2 trial is quite interesting. While oxaliplatin or irinotecan is currently used for these patients in the clinic, our Italian collaborators were using highly aggressive therapy of FOLFIRINOX, which is a combination of triplet chemotherapy plus bevacizumab, which is VEGF or anti-angiogenic therapy, and they compared that to the doublet FOLFOX plus the bevacizumab. So this TRIBE2 trial is a landmark trial, and again, this based on this, some of the guidelines could be changed for the colorectal cancer. So we got in touch with the collaborators and asked them that if we could use their clinical trial samples to see how our CRCA center or CMS, which is an extension of CRCA, could be used for the prediction of therapy in their context or setting. And interestingly, again, this paper got published, and CRCA clearly showed the stem-like subtype patients would respond to these triplet therapy compared to the others. And if sometimes these patients can have a mixture of all these subtypes, and those patients could also respond. And what we found from this is the CRCA or CRCA center is more predictive, and CMS is more prognostic, and knowing their role in the biomarker space is quite important so that we can apply it in that way. So this is the way we continue to update our retrospective data analysis. Still, we continue to do retrospective. Prospective would be great. That is what we are next step are. But still, we are successfully using the retrospective data to update the diagnostic tools. So, and this is how we globally collaborated, including in India with the Shankara Hospital, with Corley Morla. We developed a small biobank for colorectal cancer to just look into it. Of course, it's a retrospective, not really to look into treatment, but prognostication and other stuffs. But however, we believe at some point we could build data within India to look into a larger scale to see how the CRCS and CMS built from the Western world could be useful here as well. But I will show a couple of slides if we have time towards the end. So as I mentioned, every 2 to 4 years in oncology, the guidelines potentially change. New drugs would come into play. Combination drugs are very common, as I have listed. For example, KRAS G12D inhibitors in lung cancer. When I was in a graduate school, KRAS was not druggable, but that's not the case anymore today. Immunotherapy was not an easy task, but not anymore today. So, things are changing over the time, and we have to get updated up to those. And that is the challenge that today's AI face. So here is again the KRAS scenario, which I discussed earlier as well, that the extended RAS is the diagnostic tool today for cetuximab. If they are not mutated, then those patients are treated with cetuximab, but earlier it was just a KRAS alone. However, that means the AI tool need to update based on the current scenario rather than sticking to the old guidelines. Again, the gastric cancer, needs to be updated to the FLOT and immunotherapy-based treatments that's currently available in the clinic, rather than sticking to the ECX therapy, which MAGIC trial initially began with. With the rare cancer types like pancreatic neuroendocrine tumor, which is again is a part of the pancreatic cancer, but it's very rare. When it comes to the rare cancer, it is quite challenging to do both retrospective and prospective trials. Prospective trials are even more difficult because recruiting patients takes a longer time to get meaningful results. So we began our journey in pancreatic neuroendocrine tumor in 2015. We first classified like pancreatic adenocarcinoma and colorectal into different subtypes, which we call MLP subtype, IT insulinoma-like, as well as some other subtypes, not going into the details here. But we use microRNA and mRNA in the training set to do this. But in 2017, WHO decided to introduce neuroendocrine carcinoma. Until then, there were only neuroendocrine tumors. So 2015 to 2017, there was a jump that needs to be updated. And then 2018, the lutetium dotinate got approved in these patients. That means if you wanted to predict response using these subtypes, then it has to also take into consideration this therapy. But now we are in the era of single cell spatial, where high resolution data, not only for neuroendocrine tumor, but other cancers are also quite important to understand much more about how do we update this. And I will probably quickly take you through some of the technologies that are quite important that also makes this retrospective data useful or not. So, as you know, from the days of PCR or Sanger sequencing, we have gone too far with technologies improving every other month and difficult to keep up, and very expensive technologies, but high resolution. This is more like, bird's eye view of Google Map rather than, going into the details with the CCTV camera on a street where you can find what is happening on the street. So similarly, the from bulk RNA-seq, which kind of opened up a lot of space in pre-2014 to single cell era, where you can look at the single cell and ask what type of cells they are, to spatial era, where not only what type of cells, but where they were sitting, who are their neighbors, and what are they doing potentially. So that's the level we are currently. And this is again a bit of repetition of the technology to the amount of data that you collect. And we collect several petabytes of data, and it's a big challenge to integrate them as well, especially the clinical parameters, clinical information, treatment information is quite important, and integrating them with them is the challenge. And that is also the challenge is also evolving as the technology evolves as well. Because one patient, data is a different thing from one patient getting more data. So I got less than 10 minutes, but I will just be finishing soon now. And more than anything, heterogeneity matters. And single cell spatial data could zoom into those heterogeneity and provide you much more information. And here is though I haven't talked much about triple negative breast cancer, which we work largely in the context of Indian breast cancer, which I will touch upon later with the bulk data. But to be in the context with the triple negative breast cancer, we looked at different subtypes again based on the immune data. We call them immune type 1, 2, and 3. But when we zoomed into this by using single cell spatial data, we could find the type of cell types that are infiltrating into tumors, which we call immunotype 1, which includes mainly the T cells and B cells, of course. And the immunotype 2 has less of those and more of T regulatory cells. And then immunotype 3 are more into myeloid and less into the adaptive immune cell type, which obviously projects to the point of differential prognosis and therapy responses, which is quite important today to determine who will respond to immunotherapy or not. So, with that, the tools, AI tools also matters. We developed a tool called FenMap. Again, due to the time, I'm not going into the details of FenMap, but we have different versions of FenMap. We have FenMap that integrates mainly one omics data like RNA-seq with clinical data, because as I said, clinical data and treatment are the most important with changes. So that needs to be integrated together during AI modeling. So that's how we develop this FenMap, but that can also be done with the multi-omics data as well. This was a freshly published day for yesterday, and also covered by Guardian and others, where we tried to find biomarkers for the anti-angiogenic therapy using such kind of tool and copy number and mutations. Long story short, we could identify interestingly B2M deleted genomic region, which is associated with the cancer cells escaping from the immune cells, to also BRAF mutation, which is very well known in the colorectal cancer. Together, we could develop a risk score similar to what I talked about gastric cancer. We developed 4 risk groups based on risk scores, and we could not only show that there are high risk and low risk patients depending on prognosis, but we could also show the response to the anti-angiogenic therapy in these patients. Of course, again, this got published in scientific reports for a reason, because we couldn't get the appropriate retrospective or prospective cohort to validate this. That's the most important. When we cannot validate, then it is still a hypothesis that that we are very much willing to identify cohort to show that whether this could be useful to help patients find the right treatment. A last bit to say that one cohort is not every patient. That means population matters. Things predicted in the Western world is not going to be useful in the Indian setting. For example, Asia cancer incidence and deaths are more in Asia. Colorectal cancer is more prevalent in the Western world than India. I know it's probably increasing over the time in Asia as well. This is something I borrowed, but this landscape is quite different, still being understood. But there is it seems like more triple negative breast cancer in India than the Western world. If this is true, whatever we are studying and treating about these cancers are probably not completely true. So several years back we worked with Aruna Kolimala and colleagues from Shankara and the St. John's to collect a TNBC cohort of about 88 patient samples, and we did some profiling to understand the immune landscape of it. Of course, the biology was not different from the Western world. The prognosis was slightly different. Of course, that would attribute to the lifestyle of the patients. And I said we are further studying them at the level of single cell and spatial and other things. We also, with Aruna, collected the colorectal cancer patients, very small cohort of 34 patients, and then we found that CMS subtypes can be identified here. However, what we found probably CMS4, which is poor prognostic, or the stem-like subtype, which is poor prognostic, seem to be much more in Indian population. But this is a very small cohort to conclude anything, but this is a good cohort to generate such kind of hypothesis. If that is the case, maybe the treatment need to be considered differently in these population. So to kind of finish up, so myth versus reality, more data doesn't mean better for AI, because having 11,000 TCGA tumors with no treatment related information only gives you biology, but not something for a real-time clinical decision. That applies to many other larger cohorts. Unless otherwise clean, up to date, the treatment information is available. I'm just going to skip this for the time being, and when it comes to the generalizability, the question here is that the four questions one would need to ask: who was studied? That means the population that used for that particular study for the AI. Where was it done? Was it in Western world or Asia or India, rural, urban? That's also important. When was it trained? The timeline, which I kind of emphasized throughout my talk, and how was it validated is the most important things. And again, I'm going to skip. I have talked enough about validation. I guess the internal temporal validation, geographical validation, external validation, many validations are needed, and if possible, prospective validation before that gets into the AI, and that, for example, for GC risk assessment we did, but still it's not valid because it's not up to date. So I want to finish with the three questions that anyone would ask with the AI tool is that: who was it trained on? Where was it developed? When was it trained? Are the important questions that one would ask. And to finish up, I believe I have taken you through to share that AI has expiry date, so be mindful of that. Subtype biology may hold, but treatment implications expire. India has probably different types of cancers that needs to be studied, and more data doesn't mean better AI. It's also important to see what population and what kind of data you're modeling. So who, where, and when every single time is important before you treat. With that point, I like to thank for this opportunity.
Thank you, Anguraj. Indeed, it's a great learning. Being an oncologist, I can learn more, but there are few people in the audience who are from the general public. So for them, sometimes it may be going overboard, but the wealth of the experiments that you did, the way you classified, the amount of retrospective data you studied means a lot. But there are questions which are very generic and general. Dr. Prakash, can you just read through them If you want, you can answer it, or if you want to take a help of Dr. Anguraj, please let him answer.
And thank you, Anguraj, for a wonderful session. And there are few questions that I could able to summarize from the participants, what they were asking. And they were specifically asking any time frame to call it as a retrospective data, and how to find out and how and when AI models were trained. So it is just to ask them, or is there any another way that you can identify what is the retrospective data for a specific scenario, or how to find it out? This is the first question. Can you please help?
Yeah. So anything that you use that was collected before is considered as a retrospective data. So if it is not freshly real time, then it's retrospective. Even a clinical trial prospectively done and all the samples are collected to analyze them at some point will be considered a prospective trial, but retrospective analysis. So anything you collected in the past is, if not real time, it is retrospective. First thing to answer. So what is the second question? Sorry.
Yes, second question is they were asking from when the biology of the disease remains same in most of the cases is what people express, a few people, then why the AI algorithms need to be trained on the newer treatment options? As an extension, if the data is clean, why the retrospective data should not work in subsequent cohorts? You have answered that one partially, but specifically, few people have this question in the mind. Probably some scenarios it is applicable, some scenarios it might be partially applicable. If you can throw some light on that one, that will be great.
Sure. So of course the biology doesn't change. It doesn't mean the treatment landscape would not also change. So as I mentioned, it all depends on the guidelines. If there were scenarios where I showed that in colorectal cancer, cetuximab has been used for decades and it has not changed. In that scenario, any learning from the retrospective data related to the cetuximab mostly would not change, and it is reasonable to use that data to derive for the real-time treatment of the patients. Whereas I was showing in the gastric cancer that the chemotherapy that we modeled initially, the ECX therapy, is not anymore a standard of care. That means even though we could generalize to the biology that aggressive tumors respond to chemotherapy, but to what extent we don't know until or otherwise we validate and do the analysis with respect to the new treatment into the context. So I mean, there was also a point that you mentioned in the previous point is that when do we know whether it's updated or not? Of course, you have to ask the people who developed it, because unless otherwise it's clearly stated elsewhere, we would not know. That's why the whole point is you need to ask them. And similarly, you need to check the guidelines. You need to study the original paper or whatever they have provided to make sure that they're up to date. That's the only way you can really keep yourself updated.
Yeah. So there is another interesting question that if you are trying to develop a new model or trying to from the previous one, and if the vendors tells that, oh no, we cannot use the previous data that was in a retrospective fashion, then what could be the options that we might be having? So this is also one question that one of the participants has asked.
So sure, then the only option is to go for the prospective collection, right? So prospective, which is going to be super expensive, of course, but if the budget allows, if the study allows, then the best way to do that is to prospectively collect. The advantage of doing a prospective collection is that then you know what you wanted to collect, not only from the tissue biopsy point of view, but also the clinical information, electronic medical record point of view. So you can really come up with a strategy to see what you wanted to collect. Prospective clinical trial, a randomized clinical trial is even best option, but it all depends because it's already a standard of care therapy. It is huge. It's difficult. I don't know in India, but in Western world to actually conduct a randomized clinical trial for a standard of care, right? Because it's a standard of care, and you cannot say for a patient that you cannot treat them with the standard of care. So there are problems, but the long story short is that the prospective collection would be the best way, so that we can fill probably most of the gaps that retrospective data left with.
Okay. And one more question related to the way how generalizability. So how well do the AI models that were trained on the Western retrospective cohorts translate to diverse populations, and especially they were quoting like Haryana or North India.
So, so biology is one way to generalize, right? Biology is one thing which is you can anchor to, which will not change. The biology of a tumor is never going to change. It is biology, right? So, for example, in generally people know that what is any chemotherapy you take, right? There are varieties of different chemotherapy. Of course, their mechanism of action are different, but largely chemotherapy kill highly proliferative cells. We all know that. So that is one generalizability that you can go for, but that is question here is that enough to go geographically across? Probably yes, but that's not going to be accurate enough. That means, unless otherwise your AI model was trained for each of those chemotherapies, right? It's not going to be I mean, you could say that 50 to 60% of the time it works, but is that good enough? Or 40% it's working, is it good enough? Or 99% is working good enough? It all depends on the how much you have trained with the right data.
Okay. And another interesting question is, any AI model based on European data, which could have updated, still different than Indian population, may lead to a misdiagnosis or improper treatment, right? So how you know that how to handle, how doctors should handle this kind of a crisis situation?
So if I understood correctly, so they're saying the European data similar to the Indian data and still diagnosis varies? Is that what you're?
Yeah,
Let me,
varies, and then
let me
how
take that
doctors
question,
should
Anguraj.
take a call.
So, if at all I get a model or recommendation based upon the European model, something like a predict best or something, and if you suggest something in India, if it is not working, it is my responsibility because we haven't trained it. So, any model which is not trained in the local data is not applicable.
Yeah, you have to be cautious about it. But I mean, I'm not an expert. You are the clinician, so I don't know if majority of the therapies currently in India were properly assessed from the Indian population is a question, but that's the way to go ideally.
Exactly.
I do understand that it's a matter of time and funding and many other things, but
Right.
assuming from a biology saying that yes, oh, the triple negative breast cancer is triple negative breast cancer elsewhere, probably true, and mostly true, but still the lifestyle of the patient is associated with that particular tumor and the patient being poor prognostic or not. And I was talking to someone, expert in breast cancer, and they said that 3 decades back, whatever the Asian-based breast cancer patients being diagnosed and the kind of prognosis was the similar thing in the UK. Until the current guidelines came in and the way things were just assessed, because the lifestyle of the people 3 decades back in the UK were very different, and today is very different. So similarly, the lifestyle and many other factors need to be taken into consideration. That is also part of the AI-based data mining, if at all need to be included. So that matters as well. So long story short, unless otherwise it was done in that population, still it's a big question whether we are using that is right or not. I don't want to go into a lot of ethical stuffs, but
Right.
that's the ideal scenario.
Yeah.
Right. So
Thank you
there
very
are
much.
a lot more questions, Prakash.
Yeah.
Just we have last 3 minutes, so I just want to sum up. There is a feedback which is going to say that let us focus more on how do we apply. So this is something which I want to take it to as a very positive feedback, constructive feedback. So we appreciate what the speaker has applied in his real lifetime. But next, I can say module, we will ensure that either speaker demonstrates or we will let the audience do a part of it, so that if some subset feels that they're disconnected and we want to just connect them back. Right, Prakash?
That is very good, actually. Thank you very much. And most importantly, even we take one use case, there will be a lot of applications of this use case in other domains as well. So I humbly request the doctors to take this particular as a use case and try to see that how this is going to be applicable for the remaining domains as well, because the concepts looks pretty clear. As a technical person, I can definitely appreciate those particular concepts that were mentioned by him, but the use case will change, and that's how the context is extremely important in medical. And we may not able to touch each and every context, but that is a very good summary by Dr. Suresh yourself and Dr. Anguraj. Thank you very much.
So the last 1 minute, any quick closing remarks, Dr. Anguraj, Dr. Prakash, before we say thank you very much for both of you?
Sure. I mean, from my side, of course, I mean, I know only cancer, so I just gave some of those scenarios from my side. And if something is not clear, please contact me or contact Dr. Suresh and Dr. Prakash, and I'm happy to answer some of these concepts. But of course, as Dr. Prakash said, this is overall from cancer point of view, but this could be applicable to the other fields as well.
Yeah.
Thank you very much for the opportunity.
Yeah. Thank you. Thank you very much, Dr. Suresh and Dr. Anguraj.
Thank you. And back to you, NBMS, for any closing remarks.
Thank you, Dr. Anguraj sir, for this wonderful presentation. And thank you, Dr. Prakash sir. Thank you, Dr. Suresh sir,